Assalamu alaikum, my dear candidates. How are you all? Hoping all are fine and doing practice. Really, I saw after announcing more candidates being very active. Actually, this 45-day course main aim to build the confidence. If you do practice every day, it will make you confident. Okay, is that my voice clear, my dear candidates?
Yes,
Yes,
ma'am.
ma'am.
Yes,
Okay.
ma'am.
Yes, ma'am.
Yes, ma'am.
So, thank you, doctor. So try to be active because when you will be inactive, it means you losing your practice. Even sometimes as we do duty schedule, many family issue, personal, there's lots of things, but we have to make sure that time I have to enter the group and I have to solve the question and discussion and chat what we discuss. Because intermittently I always keep updated some time schedule, sometimes as hurry, some date, as one candidate was asking me frequently that today's session or tomorrow's session, somehow it missing by 9 but it is 8, but group description it was correct. So always see on the group description, so the schedule will be posted, which the fixed. Because today's session is extra session, neurology session I always take one session, but uh, recently few topics added from where MOH and saw the lessons they asking regarding the cerebral CVS team, cavernous sinus thrombosis, some topics. So I thought some topics I have discussed more, and I have to do elaborate more. That's why extra session again. And tomorrow will be the neurology session, and there will be also gynecology session. So let's start our session. Cavernous sinus thrombosis question actually recently asked from the MOH, and few recall I saw. That's why though one question asked me, it is important for all candidates. They may ask from them. Okay, so scenario was easy, but you have to know what are the risk factor and what are the presentation. Cavernous sinus thrombosis, I always specify one factor. What is the causes of thrombosis? Okay. So causes of thrombosis commonly they ask from any malignancy, any chronic infection or trauma. But question was from patient case of ACILI or antiphospholipid syndrome, like that way, and thrombosis happens. So antiphospholipid syndrome ACILI presentation means connective tissue disorder. So patient suffering from connective tissue disorder, it means patient high risk for developing thrombosis. So you have to make sure the surrounding background information. Though these are the exam question, so I was highlighting the presentation was nice. That fever was there, periorbital edema was there. Cranial nerve palsy 6 most common. So 6 means what? Abduction. And visual acuity decreased. So cavernous sinus, this cranial nerve 3, 4, 6 and this trigeminal nerve division ophthalmic maxillary, and this is the cavernous and cystic. So when it thrombus, so visual acuity loss commonly. And Candice nicely also guessed the question. But the thing is that background information you can't be missed. So again, how you will investigate? You have to investigate by CT scan initially, but always definitive. We have to make sure the site of the lesion, site of the thrombus, which cranial nerve injured by MRI. Initially, we have to do the CT. There's no role. I don't know. Some candidates telling me, ma'am, why I am not doing X-ray? What is the role of X-ray here? No role of X-ray. A patient comes to your hospital with red eye, with visual acuity diminished. What is the role of X-ray? There's no role. So CT scan and definitive is MRI. Definitive management also heparin or surgical consultation I have to take. So IV intubate is still they didn't ask, but heparin question they asked clearly. We have to thrombolize, we have to anticoagulate the thrombus. So this way, this cavernous sinus thrombus was the question. When my candidates will enter, can I mute the mic? So these are the pattern of the question, the causology, and we have to make sure the patient presentation with periorbital edema, ophthalmoplegia due to fixed nerve damage, third and fourth means what? Yesterday I say that my manom is SO4 LR6. SO4 means superior oblique muscle supplied by fourth cranial nerve, lateral rectus muscle supplied by sixth cranial nerve. So, and there is a piece, parietal inferior, temporal superior. This is the manom. So, we have to remember this 4, 3, 4, 6. These are the presentation. These are the involving common cranial nerve for the cavernous sinus thrombus, and there will be maybe the periorbital edema. There will be the sometimes visual acuity loss, patient presentation according to the question. Lateral sinus thrombosis is sagittal sinus thrombosis. It's not our headache. Our headache is cavernous sinus thrombosis. It's the exam question. Epilepsy, very important question. Even few candidates recently faced 2 questions. Even nowadays in Viva, they are asking from the epilepsy management. They take short Viva in hospital-wise work if you want to do. So epilepsy, 2 main category, generalized and partial. Partial seizure may progress to general seizure. Myoclonic, it could be atypical absence, atonic clonic seizure. So generalized seizure, grand mal, clonic, petit mal absence seizure. So I always emphasize on this word, tonic-clonic, or this word they keep on exam. Tonic-clonic, absence seizure, brief or rapid muscle jerk, myoclonic. So myoclonic means only muscle problem, and partial seizure progressing to generalized seizure. So these are the generalized seizure types, and partial seizure types are that simple, no loss of consciousness or no disturbance of awareness. Actually, this partial seizure question from the baby side or from the child age, they ask. Complex consciousness will be disturbed. Temporal aura, there will be the deja vu will be there, and motor Jacksonian. So Jacksonian means what? Jacksonian means chronic discharge of electricity from the motor cortex. So it is a motor seizure. So this motor seizure means your motor movement will be impaired. There will be jerky movement. There will be the contralateral motor side, ipsilateral motor side, consciousness will be impaired. If temporal lobe epilepsy, there will be the unreal feeling or deja vu like feeling or hallucination, delusion will be there. So my dear candidates, just listen carefully. Exam question not from generalized or partial seizure scenario. They ask management, but we have to make sure it is tonic-clonic or partial or complex. Because In pediatric session, seizure question, partial seizure, absent seizure they ask, but in adult medicine they ask by the management option. Absent seizure, petit meal, generalized epilepsy. Absent seizure, generalized epilepsy, that is mostly seen in children. My dear candidates, just remember absent seizure for the children age is 3 to 10 years. Absent seizure patient is quick recovery. Mom come to your hospital and told that the problems of the child. Even baby can't know what happened. We have to do exam question, we have to do electroencephalogram to see symmetrical 3 Hz spike. Even this is the exam question. Bilateral symmetrical 3 Hz spike we will see in the EEG, and they ask a question what is not true or which is except, like that way. So this sentence very important. Child, age, unawareness, patient don't know, quick recovery, and EEG finding. Management, first line management, always sodium valproate, ethosuximide, but they ask from the sodium valproate initially what we will do. Good prognosis, and if absences are exacerbated, you can give carbamazepam, but listen carefully, sodium valproate enough. Juvenile myoclonic epilepsy, idiopathic cause or general epilepsy. This seizure could be the juvenile absence tonic-clonic. So, prognosis extremely favorable. Precipitating factor are the menstruation, sleep deprivation, alcohol. They need lifelong drug treatment because there's a predisposing factor, aggravating factor. So juvenile myoclonic epilepsy, whatever they said, myoclonic jar, tonic-clonic seizure, we have to make sure the management will be the sodium valproate first, and again as well it is lamotrigine and topiramate. This lamotrigine option they ask in exam by which is safest in pregnancy. So it is the lamotrigine. So I discussed 2 to 3 questions from the absence seizure, electroencephalogram management, and juvenile myoclonic. If you can't remember the juvenile myoclonic, just remember it's a tonic-clonic type or myoclonic type. It could be the absence type, but predisposing factor of the menstruation, sleep deprivation, its the prognosis good, and the lifelong management they required. Epilepsy treatment, we have to do EEG and we have to assess the neurological deficit. Is there any structure abnormality present or not by neurological consultation? So we have to make sure we have to give this anti-epileptic drug after first seizure if any of the following. Means when we'll give the anti-epileptic drug? If after EEG we are seeing there's unequivocal epileptic activity, or we are seeing there is structural abnormality, or there is any neurological deficit presentation. So we have to make sure this presentation, though they will give definite sign for your management. Regarding the tonic-clonic seizure, jerky movement, there is a alteration of the sensation, thinking, and there's a motor dysfunction, sensory dysfunction, déjà vu, feelings, hallucination, temporal lobe affected. So this way. So generalized tonic-clonic seizure, sodium valproate we have to give, and secondly lamotrigine, and they ask directly for the pregnancy. The patient taking the sodium valproate and planning for the pregnancy, which drug is safest? It is the lamotrigine. Absent seizure and petit meal seizure question they ask from the, I discussed already, age, and if exacerbate we can give carbamazepine. Same as myoclonic and partial seizure. We can stop infertility if any patient come to hospital and seizure free more than 2 years. Even a patient planning for pregnancy and seizure free 2 years, we can stop anti-epileptic drug. But we have to keep on observation. And benzodiazepine, we can't stop suddenly. We have to sudden gradually. Status epilepticus, we have to this question, emergency question. Sudden a patient come to hospital, diagnosed as status epilepticus, how you will manage? They ask stepwise. Stepwise management, first of all, status epilepticus means we have to protect airway first. We have to start oxygenation. IV or rectally. Benzodiazepine. You are a doctor or clinic, there is no option of IV form. Start rectally. This is the exam question. No cannulation way, or there's no scope of for doing any cannulation. How will you manage? Exam question. We have to start rectally. So benzodiazepine, IV or rectally, lorazepam preferred because this is long duration. So long duration lorazepam, it depends on the option what they said. If they put in the option lorazepam, mark it. If patient does not respond, repeatedly we have to give after 5 to 10 minutes. This way they ask that patient, you already given benzodiazepam parenterally, but 10 minutes later again same symptoms not responding. How you will manage? We have to ensure parental anti-epileptic agent. We have to should start. If no, we have to give IV phenytoin. If no, so see the steps: benzodiazepine, then phenytoin. Last option is halopid or propofol. Same way exam question, stepwise management. Benzodiazepine is not working, so we have to ensure parental form. Parental form we give already not working. We have to ensure IV phenytoin. It's not working. We have to ensure anesthetic agent. Phosphonatoin, they like very much phosphonatoin. So when they give lorazepam not working, benzodiazepine not working, how will mark phosphonatoin or phenytoin, whatever the option. Very rarely still I found 1 or 2 questions regarding the propofol or happened the last stage we give into anesthetic agent. So this way we have to remember. The side effect of the anti-epileptic drug, dear candidates, just remember 2 to 3 questions from the sodium valproate, mainly thrombocytopenia, sodium valproate pancreatitis, and it causes alopecia. Lamotrigine causes Steven Johnson. Phenytoin causes gingival hypertrophy. Enough. What I had marked. I'll post those PDF, no issue. If you can remember, it's okay. This PDF or images, whatever after a session, keep on hearing my session. Whatever the topics I'm giving emphasis, those topics you will read, because every topic no need to read. Epilepsy management in pregnancy and breastfeeding. Just remember, as I said, aim is monotherapy. We can't give sodium valproate as it causes neural tube defect. We have to ensure folic acid, but we can't give sodium valproate as there is a teratogenic effect. We have to make sure sodium valproate that it is associated with the neural tube defect, and we have to change it. We have to change, and the safest drug is the lamotrigine, and phenytoin side effect is the cleft palate. Side effect important. So this way we have to make sure the side effect of the drug and the choosing option of the drug. Benign position of vertigo, multiple sclerosis, I already discussed. Exam question from the teenagers. Shortly I want to describe. Meniere's disease associated with tired, hearing loss, vertigo. My dear DHA candidates, heart candidates, every candidate remember Meniere's disease, hearing loss, vertigo, tinnitus. That's it, and sensation of fullness. Acoustic neuroma, 5, 6, 7 along with the vertigo tinnitus. Absence of corneal reflex along with neurofibromatosis type 2. So acoustic neuroma details I will discuss later. Just remember acoustic neuroma question they ask straightforward. How? They ask from the 5, 6, 7 of neuroma means what? Corneal reflex absent, facial nerve impaired. It is associated with the neurofibromatosis type 2. It is present with me hospital with vertigo tinnitus. So this way acoustic neuroma presentation will be there. Just make sure it is acoustic neuroma. There is a cranial nerve involvement. Otosclerosis is related, though just remember shortly it's a conductive deafness. That's this because it's not still come in the exam. These two options and is the from the recall. Drug-related tinnitus, aspirin enough to remember. Loop diuretic, aminoglycosides and quinine. Quinine also you have to remember. So aspirin and quinine for the tinnitus exam question. Meniere's disease I already discussed the triad. Remember those way. And acoustic neuroma 578. Only absence of corneal reflex, facial palsy, hearing loss. That's it. Because this triad they give and we have to make sure the diagnosis. Rayner's and Weber's test in ALA no many recall there. Just make sure one thing. Sensory neural deafness we do by Weber test. This actually question from the Weber test. Rayner's test we do by for the conductive deafness. When bone conduction will be impaired, so it's a conductive type deafness. Weber test phenomenon is if we keep the tuning fork in the middle of the forehead and we are asking, would you hearing the sound normally? If it is localized to the unaffected means I'm keeping the tuning fork in the middle. My right ear is good and left ear is disturbed, but I'm hearing in my right ear, my unaffected side. So it is unilateral sensory neural hearing loss. Opposite side, not affected part. Exam question, DHA candidates. Conductive deafness, affected side. If I hear, yes, I can hear in my left side, so it means I am hearing my left side means it's a conductive type deafness in the left side. So remember, Weber test we do sensory neural deafness in the unaffected part of the ear and affected part of the ear it will be the conductive type deafness. Okay. Question I will discuss many after the topic wise discussion. Idiopathic intracranial hypertension question from the MOH candidates. Though I emphasize few topics, kindly keep on mind that we have to read shortly. Idiopathic intracranial hypertension risk factor we have to remember. Risk factor are the obesity, female age, pregnancy, drug, oral contraceptive pill. That way they ask and the presentation will be the blood vision, papilledema, endless blindness spot. That's it. And remember we have to do the CT scan though it is the normal and elevated cerebrospinal fluid will be the higher. So and there is some differential, but for the idiopathic intracranial hypertension, a female patient taking oral contraceptive pill come to your hospital with blood vision, papilledema, Cisna palsy. How I will manage? We have to give acetazolamide. We have to repeat the lumbar puncture to reduce the cerebrospinal fluid level. We have to decrease the cerebrospinal fluid level because it is higher the pressure. That's why. And we have to do lumboperitoneal shunting. Okay. So I want to put a question. This question will be discussed with me, Dr. Sabah Jason is here. Okay, Dr. Afrika.
Yes, madam.
Okay. So, Dr. Afrin, my question to you, exam question, remember very nicely that 45-year-old female come to your hospital with blurred vision, and you done a fundoscopy which revealed papilledema, and there's a history of patient taking OCP. Now, patient is very blurred with red eye, and there is a severe headache. What you will do first, initially investigation plan, second, definitive investigation.
CT scan.
I say CT scan initially you will do, but it's revealed normal. So how we'll do? We have to do cerebrospinal fluid
Cerebrospinal fluid.
pressure. Definitive investigation, cerebrospinal fluid pressure, we have to count it. If it is more than 20, it means cerebrospinal fluid pressure higher. So it is idiopathic intracranial hypertension.
Yes,
How
madam.
we'll manage? We have to manage by how? What is your management?
Management acetazolamide.
It's not working.
Weight loss.
But patient is in emergency.
Lumboperitoneal shunt.
We have to make sure repeated lumbar puncture. This is exam question. Repeated lumbar puncture, my dear. Actually, you have to remember repeated lumbar puncture will ensure decrease the fluid pressure. Cerebrospinal fluid pressure higher, so we have to make sure decrease the fluid pressure, and which will decrease the papilledema, which will decrease the visual acuity, which will improve the visual acuity. So we have to make sure repeated lumbar puncture. Clear?
Yes, madam.
Okay, thank you. So see the papilledema. This slide, my heart candidates. This slide they ask this papilledema picture. So headache already I discussed. Normal pressure hydrocephalus also exam question. Normal pressure hydrocephalus, similarly, just we have to remember shortly one or two things. What is that? Normal pressure hydrocephalus means patient come to my hospital with gait abnormality, like Parkinsonian disease, gait abnormality, urinary incompetence, so triad, dementia, urinary incompetence with gait abnormality. So reversible, it is a reversible cause. Elderly patient come to hospital, but it's not Parkinson disease. When they will add a urinary incontinence, exam paid question, it means it's a normal pressure hydrocephalus. But if they say there is a bradykinesia, rigidity, hypokinesia, dementia, what is the diagnosis? This question will be answered by Dr. Ikra.
Yes, ma'am.
Question is that a 70-year gentleman come to your hospital with rigidity, bradykinesia, and dementia. What is your diagnosis?
Ma'am, Parkinsonism.
If I say there is a urinary incontinence, what will be your diagnosis?
Then normal pressure hydrocephalus.
Excellent. This is the way. Thank you, Dr. Ikra. This is the way we have to make sure that if it is associated with urinary incontinence, it's a normal pressure hydrocephalus. Sometimes it is associated with some complication like any head injury, meningitis complication, but no need to be remembered like that way. Just remember the triad and the Parkinsonian picture. So we have to do the imaging test. This imaging test exam question they ask what, and they give a clue. Clue is enlarged ventricle. Hydrocephalus with enlarged ventricle. This is the exam question clue. So we have to make sure it's a normal pressure hydrocephalus. We have to do ventriculoperitoneal shunting. Okay. So in normal pressure hydrocephalus question, there will be no papilledema, but there is a urinary incontinence. Motor neuron disease question I will discuss shortly because in brief they don't ask, they ask the management and the presentation. So motor neuron disease is a neurological degenerative disease. Before 40 years, it's rare. So it's above 40. Just age is important. After 40, it develop. There's a type amyotrophic, primary lateral, progressive bulbar, but it is not my headache. My headache is I have to know it is MND. MND pictures is that there is a upper and lower both type. Amyotrophic, primary lateral, progressive muscular, progressive bulbar, but I have to see that what the presentation of my patient. Testiculation, absence of sensory sign symptoms, lower motor sign in arm, upper motor sign in the legs. So if we do examination of the leg, there will be the spastic type of lesion. There will be the Babinski sign positive, hypertonia. If you do the arm examination, there will be the hypotonia, hyporeflexia, wasting. Okay. So if you ask, ma'am, how I can say it is MND, you have to make sure both presentation. In multiple sclerosis, maximum presentation is the upper motor optic neuritis type, but in MND, it could be the amyotrophy, it could be the primary lateral sclerosis. So we have to know the presentation. The diagnosis, it is clinical. We do our condition study to see there is any deficiency present or not, and electromyography, the action potential will be the reduced. So MND question presentation along with the we do clinical diagnosis. So see amyotrophic, the very just for telling it's not important, but if you can remember, it's excellent. Always it need in for further medicine practice. Amyotrophic lateral sclerosis, typically lower motor neuron sign in arm, upper motor neuron sign in the leg. If you find out this kind of patient, it's a common 80% or 60% patient commonly present with amyotrophic lateral sclerosis. Primary lateral sclerosis means only you will find out the upper motor sign. There's no lower. So you may say, ma'am, it could be the MS, it could be, but don't be confused. Because why? MS always eye presentation, other urinary incontinence, voluntary problem, bladder problem. But in MND, primary lateral sclerosis is only upper motor neuron sign. Progressive muscular atrophy, lower motor sign. Progressive bulbar palsy, chewing, swallowing will be the problem. So make sure what is the my presentation. I have to make sure exam question riluzole. How I will manage riluzole? We have to give the riluzole and we have to make exam question. A patient come to your hospital. This question I'll discuss. Recent question exam. Dr. Ramzan.
Yes, ma'am.
Yeah. A 55-year patient come to your hospital. You are a doctor of emergency with severe respiratory distress and patient known case of amyotrophic lateral sclerosis. Severe respiratory distress, you done ABG which reveal saturation drop in PO2 is 10 and there is a 10 kilopascal and carbon dioxide is around 50. So in this case, initially what you will do and how you will manage?
Ma'am, I will go for some kind of ventilation, probably non-invasive type of ventilation.
Non-invasive type of ventilation. First of all, I said you, Dr. Ramzan, carbon dioxide value, right?
Okay,
we have to wash it. Carbon dioxide, I said 50. So it means patient retaining carbon dioxide, I have to make sure to wash out. As I am Dr. Emergency, I have to make sure the ventilation first. Then hydration, nutrition is the later part. But first airway. Respiratory distress, you done ABG, you have to make sure carbon dioxide retaining, saturation dropping. So give BiPAP or CPAP. BiPAP. Always carbon dioxide retention it goes towards, so we have to give the BiPAP. Okay.
Okay, ma'am.
Okay, thank you. So this way they ask this question from the emergency medicine. Just we have to keep remember that any ventilation problem, any respiratory distress, we have to see 2 points. What about the oxygen? What about the carbon dioxide? Even in exam, DHA candidates, Vomiting, diarrhea, this is the pet question. Every day they're asking. Just say bicarbonate value and the surrounding information. But for the respiratory case, see on the oxygen and carbon dioxide value. Carbon dioxide hiring, goes towards type 1 and type 2 respiratory failure. So we have to do washout. So if it is more higher, carbon dioxide is rising, so you have to do ventilation. Cerebellar syndrome, shortly I will discuss this. Each patient present with the presentation cerebellar ataxia, there is a dysdyskinesia, there is rhombus positive. So cerebellar syndrome after stroke, it could be the any multiple sclerosis, hypothyroidism patient, cerebellar presentation. Okay. Friedreich ataxia, one question I saw rarely, just one point I want to tell regarding the Friedreich ataxia regarding that it is the hereditary one. 2 is it's a genome related X25 chromosome 9. What I am marking, just make sure and you can do your note because every information not important, but it's very tough to concise it. So make sure my lecture and listen carefully. So Friedreich ataxia is inherited and the early onset and the gene is X25 chromosome 9. Age always 10 to 15. Presentation will be both lower and upper. Common with optic atrophy and cerebral ataxia. So, what I have said, a patient come to your hospital 10 years with blurred vision and gait problem. And patients' sisters have same problem. This question will be discussed with me, Dr. Pallavi. Dr. Pallavi is not here, right?
Yes, ma'am.
Okay. No need to be worried because just I'm giving information, just try to catch out. Or you are okay, or are you feeling any or it's okay to practice with me?
Yes, ma'am.
No, are you feeling okay? Or it's okay to practice with me?
Yes, ma'am.
Okay. So a 10-year-old boy come to your hospital with blurred vision and gait disturbance. Same presentation, his sister also. And they didn't give, the parents are concerned what is ongoing, they didn't do any genetic test. So what is the more likely to be caused? And unfortunately sudden glucose is the higher level. What is the diagnosis?
Mm, ma'am, Friedreich's ataxia.
It's a Friedreich ataxia. Yeah. Clean cut scenario. First of all, sister's presentation, same. And diabetes mellitus, I said only sugar is higher level means patient suffering from type 1 diabetes mellitus. Okay.
Yes, ma'am.
If I say there is a history of the sudden cardiac death, it means patient inherited with HOCM. It is another
Yes.
clue. We have to
Yes,
make
ma'am.
sure it.
Yes,
HOCM
ma'am.
inherited disease, sudden cardiac death, so it's the Friedreich ataxia. So 3 points I said: gait disturbance, blood vision, optic atrophy, diabetes mellitus, even they give twisted way, even they give incomplete way, high sugar level, that's it, nothing they said. Even history of diabetes mellitus they didn't give. They given
Yes, ma'am.
twisted. So we have to catch it's the Friedreich ataxia because this 10 years of age, there's a multiple complication. So it's the Friedreich ataxia. Clear?
Friedreich. जी, ma'am. Yes, ma'am.
Okay. Thank you, Dr. Pallavi.
Yes.
Three more question: essential and Parkinsonism. My dear candidates, 2 questions they ask. Actually, they ask from the Parkinson disease question, and if it is essential, we will give propanol or beta blocker. But how I can say it's essential tremor? That is the point. 3 more question: causes of the Parkinsonism we know, but the essential tremor. Essential tremor, we have to remember what are the causes. So It could be family history related, it is any drug related, any metabolic disorder related. Okay. Sometimes some Parkinsonism picture rigidity, hypertonia, like a patient Wilson disease, multiple system atrophy, patient taking an antipsychotic drug, metoclopramide. These drugs may cause Parkinsonian picture, but we have to make sure we know very well. So essential tremor, strong point is postural tremor, or if arm outstretched. This one important point. Another important point is strong family history for the essential tremor, improved by alcohol and rest. And there will be the titubation. So for Parkinsonism, it's asymmetrical. It's not bilateral or symmetrical. So it's asymmetric resting. So bradykinesia presentation, shuffling gait all goes towards Parkinsonism. So how I can know it's a Parkinsonism or essential tremor? They'll give the clue. For essential tremor, we have to make sure either family history positive or it's improved by rest. But Parkinsonism present, tremor present even in rest. That's it. Shuffling gait, rigidity, if it's clinical picture like that way, it's nice. It's easy to guess the question. But if atypical question, make sure I know very well. Parkinsonism tremor always asymmetrical. Essential tremor, it is rest, it is improved by rest, and there is a family history of note. A patient cerebral problem, so there will be the tremor also. There is the nystagmus, gait problem, and there's a dysarthria, postural tremor. So this is not our issue, because in intentional tremor, when you say if you take a glass, or if you in your hand there's a pen and you are asking your patient, can you touch my pen? There is intention tremor. This is called dysdiadochokinesia. I said 3 points. Just remember strongly. Dysdiadochokinesia, intention tremor goes towards the cerebellar disease. Parkinson disease, asymmetrical rigidity, bradykinesia, peeling, rolling movement, and it is in even in the race it presents. And also there is a age is the picture. Essential tremor, there will be the family history of note. Parkinson disease, shortly I want to discuss regarding that. Degeneration of dopaminergic neuron in the substantia nigra. This is the exam question. My MOH candidates, they ask where is the problem, so or where is the damage, or where is the lesion, what is the structural damage. So we have to make sure Parkinsonism disease or Parkinson's disease, there is a degenerative change or degeneration of dopaminergic neuron in the substantia nigra. That's it. Bradykinesia, tremor, rigidity is an outer head because we know very well. But the thing is that the damaging side. More than 65. Late pipe rigidity, cogwheel rigidity, tremor. This is the picture. Bradykinesia, mask-like faces, drooling saliva. These are the picture. Parkinsonism patient management, 1 or 2 question I saw bromocriptine related. Ergot derivative dopamine receptor antagonist is the bromocriptine. That's it. Just remember it. Bromocriptine, cabergoline, pergolide. This is the ergot derivative dopamine receptor agonist. We have to make sure this drug have some side effect. It causes fibrosis. Okay. So initially we can give this cabergoline, but commonly we practice levodopa, carbidopa combination. They ask levodopa, carbidopa, that's it, just remember it. But cabergoline, bromocriptine side effect, fibrosis, we have to remember. This is the pharmacological question regarding the monoaminocytose inhibitor, silicillin, catecholamine omethyltransferase inhibitor, entacapone. That's it. Anti-muscarinic drug there is, and there's a prostaglandin melstropine. If you can remember, that's it. Even if you can't, it's not so important. Neuroleptic malignant syndrome exam question. It's a maybe January or December question. One short question. Just remember, it is in atypical antipsychotic drug related. Neuroleptic malignant syndrome. Neuroleptic malignancy in atypical. A patient comes to your hospital with fever, rigidity, altered mental status, and autonomic dysfunction. There is a no sensation regarding the bowel bladder. What is the history? Background history is patient taking olanzapine, patient taking clozapine, or amisulpride. So these are all are atypical antipsychotic drugs. So neuroleptic malignant presentation is easy, but we have to make sure it's a NMS because they ask what is the diagnosis. Background information always important sudden reduction of the dopamine activity by taking antipsychotic medication. Blockade of the dopamine receptor, withdrawal of the dopaminergic agent. So when it blocks down, it causes this presentation. Dopaminergic activation deposition is deprived and it causes this rigidity status. We have to stop antipsychotic drug. We have to make sure this IV fluid, this dantrolene and bromocriptine question exam question. So we have to give selected case. Sometime we have to give this dantrolene or bromocriptine. So shortly, what are the summary? Neuroleptic malignant syndrome is the background information of the antipsychotic drug taken and the presentation due to the decrease of the dopamine activity, and patient presented with me with rigidity and altered mental status. Okay. Malignant hyperthermia question, my dear candidates, shortly remember, though it's I will discuss in surgery malignant hyperthermia. Muscle rigidity, it is due to the administration of anesthetic agent. After that, patient develop muscle rigidity, hyperparesia, excessive release of calcium and sarcoplasmic reticulum. But the thing is that causative agent is the halothane saxamethasone. So saxamethonium, halothane, investigation we have to do, CK will be rise, creatine kinase, and we have to give dantrolene. My dear candidates, after a surgery, a long-term surgery, patient develop rigidity, high temperature, what is the cause of malignant hyperthermia due to the what? It's the halothane or saxamethasone. What is the option in my exam question? That's it. How will manage? We have to make sure to prevent calcium release by giving dantrolene. Yesterday I discussed regarding the stroke. And the management. So shortly I want to review those questions regarding the statin. We have to make sure antiplatelet or anticoagulation. Dr. Reza was telling anticoagulation. Actually, always remember anticoagulation if there is if. No need to remember anticoagulation. No need. Just remember strongly I have to give antiplatelet. Don't do major mistake, my dear candidates. Anticoagulation is just opposite to the antiplatelet. So we have to give a patient stroke, okay, fine. Patient has history of AF, so we have to give a clopidogrel and warfarin. Another issue is a deep issue. But we have to make sure patient is stroke, okay, fine, and we have to give the antiplatelet agent first to decrease the thrombosis. But anticoagulation, no, except warfarin, except atrial fibrillation. If within window period we have to give this altiplase drug, if it is no, so we can give this clopidogrel, statin, and I want to make sure my candidates know very well. So My question will be different. First of all, I want to share that my candidates know very well. So this example one will be discussed with me, Dr. It's Sherin John is here. Okay. Dr. Fatima,
Yes, ma'am.
example one.
A patient had slurred speech for 5 minutes. He has hypertension and he takes medications for it. His ECG is normal sinus rhythm with heart rate of 80 beats per minute. He is otherwise well.
What is the diagnosis and how will manage?
Um, Maybe
Tell me the
it's
diagnosis.
the stroke.
How?
He is otherwise normal.
What is the diagnosis? Any candidate, Dr. Kusia, Dr. Hira, many candidates here. What is the diagnosis?
Can I
Yes,
give the
ma'am.
answer, ma'am?
Mm-hmm.
Dr. Maha is here. The diagnosis is stroke because patient
How
has
is
slurred
stroke?
speech.
Slurred
Ma'am,
speech only
patient has
5 minutes then. Slurred speech 5 minutes.
Transition with
TI.
Transition
and
is
there
2
is
minutes. TIA. Dr. Fatima, it's the TIA. It's the only 5 minutes. They didn't. So see,
transition.
the scenario is not complete. So see, this is where they ask in the exam. What you will do? They said 5 minutes. So you have to know that even they ask what is the diagnosis. If you say stroke, will it be accepted? No. It's a 5 minutes slurred speech. They didn't say it's a persistent, there's a weakness present. Only 5 minutes slurred speech. It's incomplete scenario. If you ask in examiner or exam hall why this is type of question, there's nothing. You have to mark it correctly. That's it. 5 minutes slurred speech is 3 years. So how will you manage, Dr. Fatima?
Anticoagulants.
Anticoagulant again.
Anticoagulation.
Oh, ma'am. Can I tell, ma'am?
Antiplatelet, I think.
The voice, first of all, name of my candidates, then tell me, ma'am, this is the answer. It will be nice
Ma'am, I'm
that I
Hira.
can. Hira,
I'm
yeah,
Hira.
tell me.
Ma'am, we
Tell
will
me.
give aspirin. Aspirin.
Antiplatelet or anticoagulant? What is the difference?
Antiplatelet, ma'am. Anticoagulants we do
Antiplatelet.
not give. Yes, ma'am. TI and stroke we don't give.
We don't give. Clear,
Yes, ma'am.
Dr. Fatima? Clear. My dear Dr. Fatima, we have to make sure this long-term management, statin clopidogrel, aspirin for 2 weeks followed by clopidogrel. This is the management. But in exam, if they said it's statin aspirin, initially we can start, but after 2 weeks, whatever the exam question, according to we have to mark. So if you say, ma'am, I'm telling that aspirin, yes, we can start aspirin, no issue. But we have to make sure that aspirin first. There's no history of the atrial fibrillation. There is a, my dear Fatima, anticoagulation, just forget it. Actually, strongly I'm recommending just forget anticoagulation. There's no way to give anticoagulation. Anticoagulation means another thing, the blood thinning medication for atrial fibrillation. Antiplatelet agent, antiplatelet aspirin. Okay, so antiplatelet agent for the stroke, we have to give in this MI patient, okay, myocardial infarction, ischemia. So aspirin, another important point that we have to make sure aspirin 2 weeks, then followed by clopidogrel. Though they don't give this way, just remember we have to follow this way. Example 2 will be discussed with me, Dr. Kishori.
Yes, ma'am. I'm here.
Example 2. Yeah.
Ma'am, can you zoom? Ma'am, can you zoom? It's very tiny.
Okay. Just give me 1 minute. Yes, is it okay? No? Or
Okay, ma'am.
still okay.
No, okay. Example 2, an elderly female with no significant past medical history presents to the A&E with speech disturbance and asymmetrical weakness of face and arm. These symptoms started 3 hours ago. CT scan of the head shows no hemorrhage. Here the timing is 3 hours ago. It is it is likely
Mhm.
ischemic stroke.
Mhm.
Because if it was less than 3 hours ago,
It's a less than not 3 hours, dear. It's less than 4.5 hours. So it's a
it is-
window period. Patient
yes,
come to hospital window period, right?
yes, ma'am, window period. So we started giving antiplatelet first, that aspirin.
Antiplatelet
Yes, ma'am.
or okay, tell me your brief. Window period patient come. If patient AMI come to your hospital within 2 hours, what you will do after AMI?
After ma'am, in MI also we give antiplatelet because to decrease the coagulation.
Then
And after that, we switch to
what
clopidogrel.
what about the 6 hour, 4 hour? Why this is important? Why this window period? What is the most significant? What is the important value? Why 4 hour, 6 hour? In AMI patient, in stroke patient, what is the value of this hour?
Ma'am, I think if less than 4.4 hour, we give thrombolysis. If more than 4.5 hour, thrombolysis is contraindicated.
Excellent. Now it's okay. So what you had told before, it was wrong. Now it's okay. So
Okay,
you
ma'am.
have to do what right now?
Ma'am, it's already started 3 hours ago. So we give thrombolysis is contraindicated. So we
Why
started.
contraindicated?
Ma'am, it's
This symptoms started 3 hours ago. Means only 3 hours passed. It's still 4.5 hours not passed. If I say it's still 3 hour passed, but is it past 4.5 hour or 4
no,
4 hour passed?
actually not, ma'am. I'm sorry. I want to correct it, ma'am. Window period is not passed, so we can give thrombolytics.
Yeah, this is the point. Doctor, actually, DHA question is very easy to catch because this is a paid question. It's only 3 hour. It's actually this question is my exam question. Only 3 hour they give IV altiplus, tenecteplus, streptokinase. So what is your answer? Tenecteplus, altiplus, streptokinase. What you'll give? Three thrombolytic will be there, and I marked one. Which ones I marked?
Ma'am, we give streptokinase.
No, in a stroke we give altiplus.
Altiplase is preferred over
So
streptokinase, right, ma'am?
DRC from streptokinase tenecteplase only for MI. Okay, STK you can write every candidate STK
Yes, ma'am.
streptokinase tenecteplase only for MI. For altiplus MI, this just same question. It's then three thrombolysis was there. Another was I forget the heparin. Four option. So it's only stroke. Okay, so I can do this altiplus emergency. If I face 30 plus emergency question, another can just face 40 plus emergency question. So we have to make sure, because why they are emphasizing, because they sometimes they need emergency doctor more in Dubai, Abu Dhabi, like that way. So you have to make sure ABG interpretation, even they ask from more question from that way. So make sure in stroke, transient ischemic attack within few hours resolve. Okay, so resolve. Even they didn't say resolve, like first question Dr. Fatima missed. You can't do it. You can't miss it. So only five. It's a 5 minutes. Okay, so yeah, it's a Dr. Kishore is an excellent candidate, but sometimes sometimes disorganized. But the thing is that we have to make sure the knowledge. It's within 3 hour. It's not past 4.5 hour. So I already discussed yesterday. Though PDF I posted today, download will be there. So we have to give the articles. Thank you, Dr. Kishore. Even another strong clue there in my exam, there's no clue. CT scan excluded no hemorrhage. So strong clue. We can do thrombolysis. CT scan in clean cut scenario. CT scan done, no hemorrhage. So do thrombolysis. So long term management, clopidogrel. If AF, just I always say no need in stroke AMI, no need to remember anticoagulation. They don't give this type of cancer. If AF present, another issue. So Dr. Kishore C, within 4.5 hour LT plus. Then aspirin 2 weeks, then clopidogrel. We have to make sure the CT scan initial to see the or to exclude the hemorrhage. Another words Dr. Kishore was telling initially, I can give as loading. We can give. It's not our headache. It's a in worldwide in Europe and everywhere. There's a in emergency they is called code gray. Code gray means a stroke patient come to your hospital. Code blue, code gray. This word we have to know. Cause in ALS, BLS, all you have to do. So remember those words, and this management also very important. Broca's area associated with the frontal lobe, in which dominant hemisphere usually in the left. So frontal lobe, dominant hemisphere left, Wernicke's area temporal lobe. So Broca's means expression. We are talking, we are speaking. This is the Broca's. Temporal lobe mostly is the thinking. Sometimes some visual area there. So this is temporary. So Broca's aphasia means broken speech. Patient are telling slurred speech. Speaking is broken. There's a comprehension is not good. Grammatical disturbance. Burney's aphasia. Burney's aphasia also is speech comprehension, understanding difficult fluency will be dissolved. So Broca's area associated in the frontal lobe. Burney's area situated in the temporal lobe. Infertility drug in pregnancy already discussed. Cauda equina syndrome shortly I want to discuss, though I don't like this topic, but unfortunately MH1 exam question, one candidate was discussed. I was discussed stroke anatomy. Question was there recently in group. I was posted those recall. Just remember those recall. Sciatica, saddle paresthesia, anal, perianal, growing numbness, saddle paresthesia. Urinary retention, fecal incontinence. This picture, cauda equina. Cauda equina means what? There is a spinal cord and there is a myelin sheath, there is a nerve fiber, and there is a sacrum, and there is a horse tail like last picture. So cauda equina, bundle of nerve. This is last area of the sacrum. The bundle of nerve. The horse tail like lesion starts on T12 to 1, number 1. It compressed. It's a surgical emergency, either by any tumor like lesion or by any injury. So horse tail like lesion till number 1, we have to make sure what is the cause. So, but they ask how you will manage. We have to do urgent referral by orthopedic. This exam question, urgent MRI you have to do, and the pictures will be the sciatica, saddle paresthesia, urinary retention, and fecal incontinence. And we have to do urgent surgical decompression. Parkinsonism, all details I already discussed. Just make sure. Delirium dementia exam they ask from mainly from the delirium. Always remember delirium means acute onset. Dementia, Alzheimer's disease, Parkinsonian, frontotemporal dementia, this is the chronic disease. But delirium always occurs after respiratory infection, after urinary infection, after any surgery, sudden onset, infective type, elderly patient, immunocompromised patient, metabolic degeneration, any patient, any taking drug interaction. So it's the delirium. A sudden onset, patient feeling confused, hallucination, delirium, like that way. When you come to your hospital, impaired consciousness. So hallucination there, mood changes there. These are the delirium. So I want to discuss few questions first, then I will discuss more. This example will be discussed with me. Dr. Ifada is here. If Dr. Ifada is not here, Dr. Sachma.
Yes, sir.
It's Ifada or Sachma?
Dr. Shazma.
Okay, Dr. Sachma, read this question and tell me what is the diagnosis.
A 63-year-old is brought to a hospital by her daughter, who says that her mother has a drastic behavior and mood changes for the last 3 days. The sick lady also claims that there are thieves who enter her flat at night. So, ma'am, as it is the sudden onset and it is delirium.
Excellent. What is the cause?
Uh, uh, cause it is abrupt and
And
sudden onset
it's
है.
a sick lady. Sometimes an infection,
Yes,
something ongoing, like something
hallucinations are there.
hallucination is there, right? There's a
Yes,
hallucination there. So it is a strong
yes.
point. Goes towards the delirium, right?
Delirium.
Excellent. So this question, tell me, same question, very important exam question. Right, read this.
A 77-year-old female admitted for UTI for 12 days has developed confusion, fluctuating level of consciousness, and disoriented to time and place. So it is also delirium, as it is history of only 12 days, and she is also sick lady and uh, fluctuating level of consciousness, and she is disoriented to time and place.
So it's a delirium. Excellent. First of all, we have to catch the clue. That's a clue is real the history of the UTI. So this is causing confusion, fluctuating level of consciousness, all goes towards the delirium. Okay, abrupt onset, hallucination there, behavioral changes, but in dementia never possible. It's a chronic progressive. Clear? Nice done, Dr. Sashma.
Yes,
Thank
ma'am.
you. Yeah.
Thank you.
Seizure type question commonly my DHA had every candidate is a febrile seizure related question. Even this question they like very much. Febrile seizure question, partial seizure already discussed, but the thing is that febrile seizure I will discuss a question with the doctor. Dr. Nipuni is here. Dr. Priscilla.
Yes, doctor.
Dr. Priscilla, do you know febrile seizure management? I am telling a scenario. A 3-year-old boy come to your hospital. You are a emergency doctor, and the temperature is 102 Fahrenheit. And mom's telling there is a jerking like movement of the limbs, but not settle. But you are finding only temperature and simultaneously sudden onset jerky like feeling. So how you will manage?
Or give rectal paracetamol.
Parectal paracetamol.
Mm-hmm.
Excellent. But still, it not improved. It's still jerking there.
Okay. Diazepam, rectal diazepam.
Rectal diazepam. Rectal diazepam, they like, first of all, you given the paracetamol for the temperature cooling. But this is not tonic clonic that you have to give this diazepam. They like very much this NSAIDs. You have to give NSAIDs.
All right.
When I'll give rectal diazepam, if it is tonic clonic, I say only jerky movement. So it's due to febrile convulsion. It's a febrile convulsion. Even my dear candidate, the same question will be they ask in the medical when you give the CV, they'll ask the same question. So first of all, they like yes, paracetamol. This is not working. What you'll give? You have to give and they ask which of the medication. You have to mention it's ibuprofen, like that way. So you can't say it's an naproxen, it's ibuprofen. Okay. So you say why am ibuprofen? They just prefer this ibuprofen drug or NSAID drug. That's it. Secondly, tonic clonic seizure there, then they ask why not benzodiazepam? Benzodiazepine will not give in febrile slight convulsion. This is not tonic-clonic seizure, Dr. Priscilla. Clear?
Yes, sir. Clear.
And this simple complex seizure already discussed. So this simple no loss of consciousness complex with loss of consciousness. Okay. So some question I'll discuss. Dr. Donilda is here.
Yes, ma'am.
Dr. Donilda, you will read example 1 and tell me the management and action of you.
Example, while dancing on a stage, a known alcoholic young man suddenly collapsed and his body went off. Then there was a twitching of the legs followed by involuntary voiding. After gaining consciousness, he was drowsy and confused for several minutes before full recovery. The type of seizure.
First of all, patient alcoholic, sudden collapse.
Yes.
Then see this
Stiff.
one.
Stiff and gain consciousness. Yeah.
Stiff followed by involuntary voiding. So what type
Voiding.
of seizure it is?
Clonic seizures. Clonic.
Clonic, tonic, tonic, clonic.
Tonic, clonic.
Tonic, clonic seizure. There is a stiffness, there is a twitching, there is involuntary voiding, all there. Generalized. How will manage?
Yes.
First of tell me, ma'am, it's the first episode. I'm the attendance. I don't want any management. I say how you will investigate the patient, how you will confirm it is the seizure. One investigation, confirm it. What is that?
CT scan?
No, CT scan normal.
MRI.
What about the EEG?
EEG.
Okay. EEG. Yeah. Okay. Electroencephalogram. Okay. Yeah.
So what you say? What you see in EEG? There is a high spike. There is a in EEG finding exam question. There is a asymmetrical higher spike, more than 3 Hz.
Yeah.
Okay, I discussed. Okay, this was the exam question. Okay, thank you. So how will manage? What is the management plan, dear? What you will do right now? Patient in tonic-clonic seizure. What you will do? Anything, just you are emergency doctor, so tell what you will do involuntary stiffness,
Diazepam, benzodiazepine.
Yeah,
benzodiazepine.
So I already discussed the steps. So you have to tell me the step, ma'am. If benzodiazepine not work, I am thinking this. Tell me stepwise management. If benzodiazepine not working, what you will give?
Sodium valproate.
If benzodiazepine not working, you have to give 3 to 5 minutes later again benzodiazepine. Okay. It is in emergency. You are an emergency doctor. Then if still persistent seizure, one of the drug, any candidate, still persistent seizure.
Phenytoin.
Phenytoin, excellent. It's Dr. Donilda, right?
Yeah.
Excellent. You have to give the phenytoin. It's still
Yeah.
persistent, then anesthetic.
Sodium. Yeah. Okay.
Then anesthetic. If still persistent, then we have to choose the anesthetic agent.
Yes. Okay.
Thank you, doctor. Thank you.
Okay. Thank you.
Nicely done. Yeah. Thank you.
Okay.
Another question, example 2, just for this is the exam question, that's why I'm discussing. Example 2 will be discussed with me. Dr. Aisha Naim is here. Dr. Ifada not work, still didn't practice with me. Priya, anyone? Aisha Naim, Priya, Ifada.
Ma'am, Priya here, ma'am.
Priya read the question. And next part I will tell you.
Yes, ma'am. An 8-year-old boy, he developed a seizure firstly affecting his arm that lasted for several minutes. During the whole episode, he was unconscious and unable to.
Mhm. Unable to, I'm telling.
Yes,
He
ma'am.
was unconscious and unable to remember the events. Okay? Unable to remember the events that lead
Yes.
to his seizure. He don't know what led to the seizure. CT scan show left cerebral hemisphere there is a lesion. What is the type of seizure? You will tell
Ma'am,
me
this
the
is
clue and tell me the type of seizure. I already discussed.
yes, ma'am. The clue is that it's affecting only his arm, ma'am. So it's focal seizure. Only one part is being affected.
Yeah, no, I mean,
And
is it
there is loss of
generalized tonic?
conscious.
Mhm.
There's loss of consciousness also, ma'am.
So,
Uh, so focal seizures, ma'am.
first of all, age is 8. Age is
He's
8.
8 years old boy, ma'am.
Okay, and patient was unconscious and unable to remember. So, what happened? Patient don't know.
Yes, ma'am.
Unconscious and unable to remember the event that has gone. And the seizure was lasted several minutes. That's it. So this
Uh,
variation, which type of seizure? Is it generalized tonic-clonic, absence, myoclonic, partial? What type of?
absence seizures, ma'am.
Okay, it's not absence, it's a partial
Okay.
complex. Okay, because why partial? First of all, age you see, unconscious can't relate the event, there is space occupying lesion, focal partial, and the loss of consciousness. So it's a partial complex.
Okay, ma'am.
Okay,
Yes, ma'am.
though I said
Yes.
there's a CT scan, there's a lesion, means it could be the lesion means what? It could be the tumor like growth and hematoma like growth. There is any absence. I don't know. But the cause, this lesion caused this partial complex seizure. It is not tonic clinic. Why? Because it persists few minutes. It is not shiver, jerking, stiffness. There's nothing. It's not absence. Cause why? Absence means no loss of consciousness, but it is partial complex. It is also unconsciousness complex. Okay.
Yes, ma'am.
Okay. Thank you.
Thank you.
Guillain-Barré syndrome, myasthenic gravis, multiple sclerosis, and motor neuron disease. Just I want to tell 2 to 3 words, not more. Cause I have to mark extremely the exam question. Guillain-Barré syndrome, always ascending type of paralysis. The patient comes to hospital, ma'am, I have a history of the UTI, I have a gastroenteritis 7 days back or 10 days back. Now I can't move my legs. Now I'm wheelchair bound for 2 days. So it's ascending type. It's not descending. Descending type means what? From the upper limb to lower limb. Ascending type means lower limb to upper limb. So it's ascending type of paralysis. So it's a Guillain-Barré syndrome. First of all, history of an infection, GIT, respiratory tract infection. And there's a lower motor type of lesion. There's a loss of reflex, loss of tendon, everything. Okay. So these were they ask exam clean carcinoma. My DHA had every candidate is example clean carcinoma for the GBS. What is the diagnosis? Young age, it could be triggering factor for the infection, and the infection paralysis pattern is that ascending time. That's it. So Guillain-Barré syndrome. To the myasthenic gravis presentation. Before that, I want to make sure few words. Just give me 1 minute. Guillain-Barré syndrome management from the IV immunoglobulin. This is exam question. They ask how will manage initially. Initially, in acute flare-up condition, we give IV immunoglobulin. Okay. Another question regarding the Guillain-Barré syndrome. The investigation purpose we have to do the oligoclonal blend by doing the CSF study. Okay. So this way, 2 to 3 questions they ask commonly in the exam. We have to make sure those questions. I always emphasize to keep active on the Zoom because Zoom session, every what is very important. Every in my previous every request, just be active on the Zoom. That's why. So 1 or 2 points regarding the CSF value, we have to see the oligoclonal band, and we have to make sure in GBS there is a respiratory failure developed. So we have to do the force vital capacity. Okay, and management plasma exchange exam question IV immunoglobulin we have to give in acute flare condition, patient condition wise. Okay. Myasthenia gravis shortly, as it is actually related, it's autoimmune disorder, and patient come to your hospital with dysphagia, extraocular muscle weakness, diplopia, proximal muscle weakness. Patient can't stand from the sitting. It's a proximal muscle of the thigh. Patient can come the here cause proximal muscle weakness of the shoulder. Patient can't move the thigh muscle because there's proximal. When at the end of the day, same scenario in the exam. At the end of the day, patient eye drooping, patient can't move the thigh, patient can come the here. This is the way. It's an autoimmune disorder due to insufficient functioning of the acetylcholine receptor antibody. Exam question: acetylcholine receptor antibody defect or deficiency. Ptosis, dysphagia, proximal muscle is not in early morning, never. It's the end of the day or gradually at the ending of the day. Okay. We have to do this autoantibody, acetylcholine receptor antibody. Make sure this one exam question. No need to remember regarding that CK, CT thorax, no need. Another important is pyridostigmine, this word. We have to give for long-term chronic patient pyridostigmine, but initially acute crisis, patient respiratory disturbance, patient weakness, severely weak. In this case, we have to give initially prednisolone. Management, plasmapheresis, immunoglobulin as like prednisolone. Regarding bulbar palsy, facial palsy question regarding they asked from the facial palsy. Just remember facial palsy, 7th nerve palsy. This palsy related question. Even they can't smile, they can't close the eye. Okay. It is associated with the Bell's palsy, so weak in the facial muscle, movement of the eye and lids, ptosis, inability to close, drooping of the lower lip. These are there, and we have to give prednisolone initially. This facial nerve and trigeminal nerve question, involuntary muscle mastication problem for the trigeminal nerve injury. So trigeminal nerve, along with that, we have to remember the unilateral electrical shock like pain, sharp shooting. shaving, chewing, moving. This is the way they ask, and we have to make sure they're carbamazepine. Okay. Carbamazepine first line, we can give the lamotrigine phenytoin later. Horner syndrome I discussed yesterday, ptosis, mydrosis, and hydrosis. Anhydrosis means no sweating. So it's a Horner syndrome. Status epilepticus management already discussed. IV lorazepam, buccal metazolam, rectal diazepam, then IV phenytoin, and refer to ICU for anesthetic agent. These steps very important. Normal pressure hydrocephalus already discussed. Urinary incontinence, very important question. Bulbar palsy, pseudobulbar palsy, just remember shortly for the bulbar palsy, it's a 10, 11, 12 nerve impairment along with nasal speed and spastic dysarthria associated with pseudobulbar. Pseudobulbar palsy, gag reflex will be positive and gag reflex will be negative in the bulbar palsy. That's it. So shortly I want to discuss few questions from the bulbar pseudobulbar palsy, and it will be nice if we discuss more. So this question will be discussed with me in platform newly candidate join. So I still not interested to asking for space to listen first. Okay. So this question will be discussed with me. Dr. Moshumi is here. Okay. Dr. Umer, Dr. John. Okay. Dr. Badhon.
Yes, ma'am.
Yeah. Read this question. Dr. Badhon maybe, right?
Yes, ma'am. A 66 years old female presents with difficulty in swallowing, aspiration pneumonia, bovine cough, wasted tongue that sits in the mouth and with fasciculations, difficult to articulate certain words, nasal regurgitation of food. The likely cause of her dysphagia. Ma'am,
What are the presentation here? Here presentation
that
wasting. Okay. Waving cough is here
thing.
and fasciculation there.
Yes, ma'am. Ma'am, it's their absence of gag reflex, so I think bulbar palsy.
It's the bulbar palsy. It's not pseudobulbar because there is the absence of gag reflex, right? Strong clue
Yes,
there. So in this bulbar palsy, do you know the management in one word if you can say?
bulbar palsy, ma'am, it's the trigeminal
We
nerve.
can give
Side
no in bulbar palsy.
carbamazepine.
No, it's a trigeminal. Carbamazepine for the trigeminal. It's a bulbar palsy means what? Which nerve involved for the bulbar palsy?
So we
Which
can
nerve?
give carbamazepine. Trigeminal nerve.
Bulbar palsy, wasted tongue, fasciculation there, cough there, nasal regurgitation there.
Okay.
Facial.
Okay, then it's facial nerve palsy. Facial.
Yes. So we have to give the steroid.
Steroid,
Okay.
prednisolone.
Prednisolone. Okay. Bulbar, pseudobulbar. Bulbar associated with facial. Okay. Always.
Okay.
So my platform, I can't see the platform who are there. Anyone can unmute the mic and can perform with me example 1 and example 2, another candidate. Example 1, Fatima, Dr. DHA Fatima, not Peri, not Fatima, but another Fatima is here, I can see. Utsia, doctor. Dr. Hira.
Yes, ma'am.
Yeah, read this question.
A 63 years old female with uncontrolled hypertension prevents with right hemiparesis. Her left pupil is dilated. Her left eye shows ptosis and is deviated outwards and downwards.
So see what type of lesion it is. Cause first of all, patient has hemiparesis, right sided, left sided pupil dilated.
Yes, ma'am.
Left sided pupil dilated and left eye show ptosis. So left sided pupil dilated to show ptosis outward downward. So I yesterday discussed, this is the MOH exam question. So ipsilateral third nerve involvement along with sixth nerve involvement, and there is the contralateral hemiparesis.
Yes, ma'am.
So is it ACA, PICA? I said anterior cerebral artery, anterior medial meningeal artery. I said posterior cerebral artery, posterior meningeal artery. I said I discussed yesterday. Anterior, medial, posterior. Yes, sir. Dr. Priscilla, Dr. Priya, anyone? Dr. Madiha, anyone? Who knows?
Ma'am, it's posterior cerebral artery
It's
Weber syndrome.
the Weber syndrome, right?
It's a lateral cranial nerve third
First of a
pulsatosis
midbrain
dilated
it's a
midbrain involved.
it's a contralateral hemiparesis, ipsilateral cochlear nerve pulse is a midbrain Weber syndrome. Okay, excellent, Madhya. That is so. Actually, this is a paid question for the MH exam candidates. Just remember this way, that this is the Weber syndrome. Okay. Thank you, Dr. Priscilla. Nicely done. Yeah, Dr. Hira also tried, but nicely done. So last few topics I want to discuss regarding the Alzheimer and frontotemporal dementia. So see the same way that after AMI, left arm paralysis, sensory loss, left-sided face, and there's a gaze preference, right-sided homonymous medial cerebral artery. Same way I discussed yesterday, this question just remember strongly. Left middle cerebral artery, the scenario complication, you have to remember homonosynopia. Alzheimer disease question, progressive neurodegenerative disease of the brain accounting for the majority of the dementia. Alzheimer disease question they asked regarding the presentation. Patient come to your hospital with short memory loss and patient confused, patient disoriented. This way we have to do MRI exam question they asked from the MRI. There's impairment of many mental square, along with there is MRI finding there is a ventricular enlargement. Okay, so same way they asked regarding the minimental score with the impaired management, we have to manage by giving rivastigmine or donepezil. This way we have to remember. So the example one, just for discussion, because we have to know and how we will manage. Example one from my panels, who want to discuss, anyone?
Yes, ma'am.
Yeah, example one.
65 years old has become increasingly distressed and cries all the time. She has been forgetting to lock her doors and to turn off the stove. She, for the first time, has forgotten her son's birthday this year. She easily gets lost when she goes out. Sometimes she puts her keys in the washing machine. She has become unable to use her microwave to cook food anymore. Her recent memory is impaired. However, her immediate recall is intact. She scored she scored 26 to
Mental
26
score.
over 30.
So mental score 26 to 30 means it is mild.
Mild. Yes, ma'am. Mild Alzheimer's disease.
Mild Alzheimer's disease. So patient has emotional disturbance, cognitive behavior impairment. Okay, all there, but
Yes,
it's a mild form. Okay.
yes,
So
yes,
how
ma'am.
will manage? What is the medication we'll give, doctor?
Rivastigmine.
Okay, excellent. If it is not work, we can give Donepezil. Okay.
Don't. Yes, ma'am.
Okay. Thank you. Lewy body dementia shortly. Vascular dementia exam question. Lewy body dementia. Vascular dementia, they'll give patient diabetic, hypertension are present to your hospital. So it's a vascular. Lewy body dementia patient presented with decreased problem solving ability, fluctuating of the awareness of the attention, mild Parkinsonism, visual hallucination. So we have to do MRI of the brain. For the Lewy body dementia, these are the triad: Parkinsonism plus visual hallucination plus dementia. This is the Lewy body dementia presentation. Okay. My candidate, Dr. Fatima, only Fatima. Okay. Dr. Tamanna Tahrim. Try to be active, try to be talk, cause it will help you. Neither you will do wrong again in the exam hall. Okay. Dr. Tamanna
Hello.
Tahrim is here. Yeah. Dr. Tamanna, read this question. Key 50.
Uh, do you remember myasthenia gravis?
Patient come to your hospital fatigue. I am telling, a patient 45-year-old come to your hospital with fatigue, weakness, and normal reflex, and there is a similar presentation like normal autonomic function, but there is a diplopia, dysphagia, and drooping eye.
Yes.
Okay.
Okay.
So diplopia, dysphagia, drooping eyelid, it is not at the end of the bed. It is always persistently present, and there is a hyperreflexia. So diplopia, drooping eyelid along with the hyperreflexia. Okay,
Yes.
upper neuron sign.
Yes.
Upper neuron sign in upper limb and lower motor neuron sign in lower limb.
Yes. Diagnosis, should I say?
Yeah.
It's a motor neuron disease, amyotrophic lateral sclerosis.
It's a motor neuron disease, amyotrophic lateral sclerosis. If I say only if it is end of the day, so which goes towards the myasthenia gravis. Okay.
Myasthenia gravis.
Myasthenia
Yes.
gravis.
Yes.
Yeah. Thank you, Dr. Paul Tamanna. Excellent. So this way you have to remember this amyotrophic lateral sclerosis. So this way, this unable to arm. It is nice description that is given here. So last discussion from the shortly. Few question I'll discuss, then it will be ended. Syringomyelia question shortly. I want to say there is series on the spinal cord which cause compression and loss of sensory and motor function and upper limb. Loss of pain temperature is called syringomyelia. When it is a bulbular type, it's called syringobulbia. So facial nerve palsy, syringobulbia. So shortly remember, when there is a limb, syrinx full field space in the spinal cord and it compress on the spinal thalamic tract, which cause loss of temperature and pain. So from my platform, doctors 1, 2, 3 will discuss. First of all, I discuss from okay. Dr. Sajma is here?
Yes,
Or
ma'am.
Dr. Sajma, I'll discuss with you one question. So read this question and tell me the diagnosis.
A 48-year-old female with left-sided pins and needles in her left thumb, index and middle finger of for several months has been diagnosed with carpal tunnel syndrome. What features in her past medical history has predisposed her to this condition?
So carpal
Uh,
tunnel syndrome. Do you know the cause?
uh, Obesity.
Obesity. Excellent. Excellent. Now, carpal tunnel syndrome. Another form is the obesity. So see, presentation will be the pains, needles, temperature, and there's a wasting, thinner imminence. Tenal signs will be positive. Phalanx sign will be the positive, and the risk factor are the idiopathic pregnancy, and there will be the rheumatoid arthritis, the causology, right? And we have to treatment. We have to give treatment by corticosteroid, Dr. Sasma. Okay.
Yes.
Nice.
Yes, ma'am.
Dr.
Thank you.
Ikra.
Yes, ma'am.
Okay. Okay. Read this question, Dr. Ikra. And last question will be done by Dr. Kishori.
A 58 years old lady presents to clinic with 6 months history of limb weakness and fall. She has hypercholesteremia and takes statins. On examination, there is wasting of the intrinsic hand muscles and left bicep with fasciculations in the left biceps and shoulder girdle. There is generalized weakness with brisk left bicep and bilateral knee reflexes and right extensor plantar response. Okay. The sensations is normal throughout. Examination of the cranial nerves are normal. Diagnosis.
So what are
Ma'am,
the, yeah.
ma'am, I think option B.
Why, dear? There is a
Ma'am, because
wasting. There is a fasciculation. Yeah. There is a motor involvement. There is a fasciculation. Okay. There's a bilateral knee reflex also what? Weakened.
Yes.
Right? So your answer B. Excellent. Thanks.
Thank you.
It's the M&A. Yeah. Dr. Kishori.
Yes, I'm here.
Yeah. Last question.
Please don't read. I can see it
Yeah,
clearly.
yeah. I'll do it. Just remember. Can you read this question now?
Okay, I'll try. It's a 57-year-old woman presents with and
8-week history
week
of intermittent dizziness.
These episodes typically occur when she suddenly moves her head and characterized by the sensation
Room is spinning.
that the
Room is spinning. Yeah.
okay, room is spinning. Most attacks last around
around 1
4
minute.
okay, 1 minute before
Dissipating.
dissipating. Neurological examination is unremarkable. What is the most likely diagnosis? This she's 57-year-old and 8-week history of intermittent dizziness. Okay, she suddenly moves her head. I think, ma'am, this is Meniere's disease.
How? What is the clue? Meniere's disease. Try tell me, Dr. Kishori. What are the type of Meniere's disease?
Miss vertigo.
Then,
and
is there any option for the hearing loss? Must there be the hearing loss? Sensation of fullness of the hair. There's nothing. They said, Dr. Kishori, see, intermittent dizziness typically occur when she suddenly moves her head.
That means paroxysmal vertigo, positional vertigo.
It's a BPVV. Okay.
Yes, ma'am.
Clear?
Yes, ma'am. Ma'am, where moves her head? Okay, ma'am.
Yeah, this is the point.
Yes, ma'am. Answer A.
Yeah, answer A. Dr. Hira or Dr. Donilda last. Yeah, Dr. Hira.
Yes, ma'am. Ma'am, this one?
No. I'm giving.
Second one.
No, I'm telling you. I'll tell you.
Okay.
This one.
Okay, ma'am. A 72-year-old gentleman with a history of hypertension and stroke presents to emergency department accompanied by his wife. His wife reported him waking at 7 a.m. confused. Repetitive questions was a permanent feature. He was observed to be rubbing his hands together during the event. He was able to recognize his wife and correctly reported his address and date of birth to paramedics. The event lasted approximately 10 minutes. On arrival to the emergency department, he has Glasgow Coma scale of 13. A full neurological examination was otherwise normal. What is the likely diagnosis? Epilepsy, transient psychogenic amnesia, transient global amnesia, brain tumor, transient ischemic attack.
So what are the features here? You find out.
Ma'am, here first hypertension and stroke. He has history of hypertension and stroke first. Then he wakes up and he is confused. And then he is rubbing his hands together. But he remembers his wife, address and date of birth. An episode is lasted for 10 minutes. And Glasgow's coma scale is 13. It can't be brain tumor, TIA, no. Epilepsy, no. It's between B and C, ma'am. Now, transient psychogenic
So it's a transient psychogenic amnesia, transient global amnesia. Just 10 minutes, all lost. 10 minutes, all lost, right? So 10 minutes, all lost. Then it's already again recovered. But the thing, no. The thing is that you see, I'm telling the point here is not so easy. You have to remember that clinical syndrome, uncertain etiology, dizziness, decreased episode of few hours. So transient will be within few hours, but it is only minutes, 10 minutes. So this efficient transient psychogenic amnesia. So patient has history of the hypertension, stroke presentation, this epileptic picture. If you say, ma'am, how it is epilepsy? Is it epilepsy or not? 1 point rubbing his hand together. It is another form of simple epilepsy without loss of consciousness. Okay?
Yes, ma'am.
But it is so hard question. But remember, it can be simple epilepsy without loss of consciousness. Okay, just simple rubbing 10 minutes, because transient global amnesia will be 10 within hour. Okay, psychogenic
Okay.
amnesia will be the more than hour, but it is not like that way. Okay.
It's for 10. Yes, ma'am.
Yeah.
Okay, ma'am. Thank
So
you.
okay, thank you. Yeah. So today my neurology session I am ending. So I covered every higher topics, and my topics neurology part 1, neurology part 2 is very lengthy, and there's lots of discussion, and try to be listen if anyone feel confused, and the topics wise discussion was very important. I highlight those questions, sometimes some question atypical, typical, likewise I discuss dementia, delirium, my PDF enough to understand and to revise them. Actually, few questions very important for my MOS candidates, but with the DHA, HAD and SLE candidates, they will keep on eye on the stroke, on the MND, GBS, myasthenia gravis, this stroke management, that's it. But stroke anatomy, stroke like presentation, what are the presentation of epilepsy is important. So I always highlight those points together. So thank you everyone. Assalamu alaikum to all.
Ma'am,
Inshallah.
ma'am,
Yes.
hello, ma'am, Pallavi.
Yeah,
Ma'am,
yeah.
I have a quick question. In this Ella note, one question I have not no understand. If you explain, please. Elderly with positive bilateral Rini test and waiver test is better on the right ear. What is the diagnosis? Ma'am, answer is left sensory neural hearing loss. Elderly patient, positive bilateral Rini test. And
Rini
waiver
test means
test,
what? I was
uh,
the Rini test for
Rini
what?
test means
For sensory loss.
sensory loss.
Sensory.
Ma'am.
And
Yes,
bilateral
ma'am.
Rini test positive. Another point what? Another point what?
Waiver test is better on right
Weber
ear.
test. So Weber test is not my headache. My headache Rini test positive. Weber test right sided better means bilateral is left sided sensory neural hearing loss. Cause
Yes.
Weber is good, but bilateral means they said opposite side. I said affected area, non-affected area. Rini test.
Yes, ma'am.
If it's affected area, it goes towards Weber test. It is unaffected
Waiver.
area. It
Yes.
goes towards the Rini test. Clear?
Yes, ma'am.
So after
My confusion is bilateral Rini test positive.
bilateral Rini test positive, but you have to see positive right-sided Weber test. So left-sided Rini is
sensory neural hearing. Yes, ma'am. Thank you, ma'am.
this question no never come this way. This recall, that's why. But the exam question, every candidate nice way. What I was said, my PDF. Just remember from those PDF enough. Okay, Dr. Pallavi.
Yes, ma'am. Yes, ma'am.
Okay, thank you, my dear candidates. Assalamu alaikum to all. Thank you, everyone.
Thank you.
Assalamu alaikum. Thank you.